Assalamu alaikum. In the medical literature, a common way of describing the effectiveness of some test, be it a physical finding or a laboratory result or an imaging modality, is to report on its sensitivity and specificity. And although this provides useful information, it's only a small spot of a wider picture, and decisions should not be based on these two parameters alone. In the clinical practice, in general, there are two types of tests. There are the diagnostic tests that provides definitive information about the presence or the absence of a certain disease or a certain disorder. It's like, for example, histopathology in tumors or special types of scans, say, for example, an MRI scan for vestibular schwannomas. By contrast, there is another group of tests, collectively called screening tests. They may be a symptom, like, for example, anosmia in a COVID suspected patient, a physical finding, a laboratory result, or an imaging modality. This type of tests provide less definitive, less sensitive, and less specific information, but they may still be very useful because they have other advantages. They are more accessible, less invasive, less dangerous, less expensive, less time-consuming, and less physically and psychologically discomforting for the patients. It's usual to start with the screening tests, and if still in doubt, you can step up and ask for the diagnostic tests. It is in this context that we will discuss some screening tests, information about sensitivity and specificity. It's how close are the results of these simpler tests to the definitive diagnostic tests. And in this presentation, we shall go through some of the examples about how this information can be useful, but how it is also limited. On evaluating a test and deciding on how useful it is, the general picture includes all these parameters. Sensitivity and specificity is just a small spot of a wide picture. The wide picture contains also parameters like positive predictive value of the test, negative predictive value, positive likelihood ratio, negative likelihood ratio, and the diagnostic odds ratio. We shall go through all these 5 parameters in the next presentations, but in this presentation we shall focus on sensitivity and specificity. There are also other parameters that should be taken into account, like the validity of the test, its accuracy, its precision, its resolution, and its confidence intervals about a certain result. Plus, of course, issues like availability of the test, how invasive it is, and technical and economic considerations. First step in the evaluation of the screening test, trying to answer the question of how useful this test is, to compare results obtained from it with results obtained from a certain reference standard, sometimes called a gold standard diagnostic test. Results obtained from screening tests are seldom 100% accurate, but somewhere around 80% would be considered a good outcome in clinical research and clinical practice. There would always be a degree of false positives and false negative results compared with the gold standard. A false positive would provide a type 1 error that would reduce the specificity of the test. This would happen if we accept a faulty evidence as the true evidence and reach a wrong diagnosis. On the other hand, a type 2 error, that is false negative, is when we fail to see a positive and a true evidence and therefore we would miss the correct diagnosis, and that would be the type 2 error, and this would reduce sensitivity. And we would reach a conclusion about whether the test is valid or not. How useful is this test? If it detects most people with the target disease or disorder, then it would have high sensitivity and a minimum type 2 error, and excludes most people without the disease or the disorder. That is to say, it has high specificity and a minimum type 1 error. There are other factors like the predictive value, positive or negative predictive values, and other likelihood ratios and diagnostic odds ratio, but we'll come to this in next presentations. In this presentation we shall discuss these two factors. This will demonstrate how the results of a screening test would be validated against the results obtained from a gold standard. The results obtained from the gold standard would be in the squares, and it would be a green square if it is positive and a white square if it is negative. So these green squares are truly positive and the white squares are truly negative. The screening test results would be a red circle if it is positive and a white circle if it is negative. So in these green squares where they are truly positive and the circle is white, this would be a type 2 error, negative by the test, and positive, truly positive, would be a type 2 error. All these green squares are positive cases that were missed except for the last row here. They will be missed by the screening test, so it has low sensitivity and a very high type 2 error. On the other hand, if you see these 8 cases who are truly negative, none of them were identified as false positive by the screening test, because all the circles here are also white. So there is no type 1 error, very high specificity, in fact 100% specificity, and very low sensitivity in this example. On the other example here, you may have about 30 cases of truly positive cases here, and the remaining are negative. Out of these 30 positive cases, the screening test has identified about 60%, 3 out of the 5 rows, this is about 60%, were correctly identified as positive because they have these red circles. So the sensitivity here is 60%. The remaining here are type 2 error. Now these white squares are truly negative, and they were not identified as positive except in these last 12 cases. So all these cases were judged correctly as negative by the screening test, but in these 12 cases they were judged to be positive, where in fact they are truly negative. These are false positive tests, type 1 error. So the specificity here would decrease according to these number of false positive and type 1 error. And this 2 by 2 table is a common way of presenting the validation results obtained by comparing the results of the new test, the screening test, on the side with the gold standard test on the top. The gold standard test would set up the positive first and then the negative, and the new test would put the positive on top and then the negative on the second row. And as you can see, when the new test identify the positive test cases as really positive, then it is true positive. But when they identify positive cases as negative, then it is false negative, where it should actually be positive. So it's a missing diagnosis. It's a type 2 error. On this row, the negative cases by the gold standard If it is positive by the screening test, then it is a false positive. This is type 1 error. And if it is, if they both tests agree, then it is truly negative in here. Now, the important thing is that on this vertical row, if you have the gold standard on the top and the new test or the screening test on the side, then on this vertical column in here, you would get the results of the sensitivity, and on the second vertical column, you get the results of the specificity. Sensitivity would be comparing the truly positive to all the positive cases, and specificity would be comparing the truly negative to all the really negative cases on this column. Mind you, there are other ways of presenting these results. If you take the horizontal axis rather than the vertical axis, then you can get things like the positive or negative predictive values, the likelihood ratios by going horizontally rather than by going vertically to estimate the sensitivity or the specificity on the vertical axis. We'll come to this later. So the results of the sensitivity and the specificity obtained from this 2x2 table would tell us something about how close are the results obtained from this test, the screening test, compared with the gold standard test. It would be evaluating the effectiveness of the test. How close are its results to the gold standard? The results obtained by looking at the horizontal axis would tell us something perhaps more clinically relevant. Like if you have a positive test from the screening test, how likely you are actually positive and how likely you have a false positive. This would be obtained by looking into this axis rather than this axis. And the same applies if you have a negative test from the screening test, how likely you are actually truly negative and not a false negative. So looking into the horizontal axis would give you the predictive value, the likelihood ratios, and would give more clinically relevant information. Whereas looking into the vertical axis would tell you something about the effectiveness of this test, how close it is to the gold standard. If the new test or the screening test has high sensitivity, it means that it could pick up most of the really positive cases and label them as true positive. But it does not mean that if someone has a positive result from the new test, that he is more likely to have the disease or not. Because to answer this question, you would have to look into the ratio of the true positive to the false positive. You would have to take into account the false positive cases as well. A positive case by the new test could be true positive or could be false positive. So analysis along the horizontal axis is required rather than analysis along the vertical axis to produce things like the positive predictive value and the likelihood ratio. High sensitivity should not be confused with having a higher chance if the test is positive that you are actually having a truly positive result. And conversely, if the new test has high specificity, it means that it had picked up most of the actually negative cases as truly negative. But it does not mean that when a person has a negative result from the new test, that he is more likely to be negative or not, because then you would have to take into account the cases of false negative as much as you take into account the truly negative cases. And this would also entail analysis along the horizontal axis, not just analysis along the vertical axis. Now consider this example. If we have a new test, a screening test, test number 2, and we'll be examining 100 cases for a certain disorder. 5 of the 100 cases have the disorder and 95 don't, are normal. Now the new test has actually done very well because it picked up 4 of the 5 cases. It picked up 4 of the 5 disorder cases, so it has a very high sensitivity, 80%. Now remember, this does not mean that if you obtain a positive result from the new test, you are more likely to be true positive than false positive. In fact, in this example, you could see that the false positive cases, which were not included in the calculation of the sensitivity, are actually much higher. So the chances of a positive result from the new test with high sensitivity does not tell you how likely you are to be truly positive or not. But it shows you something interesting. It shows you that if you have a truly positive case of 4 out of 5, this is high sensitivity, then you must have a smaller number in here, the false negative, because you've missed only 1 case out of the 5 cases. And because the false negatives are low, it's much more likely that the true negative would be higher. So if you have high sensitivity, like 80%, and a negative result, it means that you are more likely to be actually negative, truly negative. You will be out of the disorders. You remember this by SNOUT. SN would stand for sensitivity, N for negative again, and out would mean that if a high sensitivity and a negative result, you are actually out, you are actually truly negative. Something very similar would happen if a test has very high specificity. And consider this example here with test number 4. There is a disorder of 27 cases have the disorder out of the 100, and 73 cases are normal. And this test number 4 has very high specificity because it picked up 70 out of the 73 normal and labeled them as normal. It has a specificity more than 90%. But because there are very high specificity, you would also expect to have few cases of false positive. So if the test number 4 results were positive, it's much more likely to be true positive than false positive, because false positive by definition here are reduced compared to the true negative. And this would sum it up. SPIN would stand for specificity, high specificity. P again for positive cases of a test with high specificity are N, that's to mean are truly positive. So high specificity, positive cases are truly positive, much like high sensitivity, negative cases are truly negative. The other issue about sensitivity and specificity reporting is that they are often reported as a single figure, like 86% or 90%, whereas it's much more useful to include the confidence intervals, particularly the 95% confidence intervals, with the figure for sensitivity and specificity. So there are formulas to obtain the confidence intervals around the sensitivity and around the specificity, and these formulas would provide the confidence intervals for 95% or 90% at any chosen level. But it's more meaningful to say that the sensitivity is 84% with confidence intervals between 62% and 94%. So the actual sensitivity in 95% of the cases would fall in between these two limits. It can be as low as 62 and can be as high as 94%, rather than just providing a single figure of 84%. And the same applies to specificity, rather than just saying it is 48% specific. The confidence intervals would go from 33% up to 63%. So in fact, the specificity for this particular example could be as low as only 33%. So finally, to sum up, there are limitations for reporting the results of a test by only sensitivity and specificity. They provide only a small spot of a wide picture. Sensitivity and specificity indicate how effective is this test compared to a gold standard, but they don't provide information about how likely a positive result is to be truly positive or false positive, or a negative result being truly negative or false negative. So they don't provide information that can be a basis for informed decision about a particular case. Plus, the issue of reporting the sensitivity and specificity with the confidence intervals, which gives a much better and a clearer idea about their effectiveness. By this, we come to the end on this presentation on the limitations of sensitivity and specificity on reporting on a new test. Assalamu alaikum.